And start with a TOPGUN session. We have one cancellation for the second talk, so I will start with my talk right now.
Well, for the first speaker is Dr. Rüdiger Lange. He's going to talk about low-risk severe aortic stenosis, TAVI versus surgical AVR. He is on the side of TAVI.
How do you advance the slides? To advance the slides?
Control.
Yes, so I have no adversary today, so I can just tell you what I think about the future relationship between transcatheter aortic valve and surgical valves in low-risk patients. If we look at Germany, here the statistics for the last almost 20 years, the last one, 2018, you see that surgical aortic valve implantation is dropping a little bit, and in contrast to this, you have a huge increase in transcatheter valve implantations. Actually, in 2018, we had 71% of all isolated aortic valve implantation with transcatheter valves. In 2019, it was 75%. What does that mean for our hospital? Those are the bars for the mechanical valves. You see that mechanical valves are almost not implanted anymore. Then the biological valves dropped considerably, and then on top you see the transcatheter valves. The whole hospital in 2019 performed 850 transcatheter valves, 450 in surgery and 400 in cardiology, and the all over implantation rate of aortic valves is rising over the last 20 years. So there's a big number of transcatheter valves being performed in Germany. It's probably the country with most implantations in the world. Now let us look what tells us the new randomized trials. Let's first look at mortality. Here's the latest Evolute low-risk trial. It showed almost equal endpoints, death or disabling stroke. And if you take those two endpoints, then TAVR has been shown non-inferior to SAVR. So they are equal in low-risk patients. Now, the Edwards company did a little trick to make it better. They had another endpoint. They had death, stroke, and rehospitalization. Now, if you take rehospitalization as an additional endpoint, then you can see that TAVR is superior to SAVR for low-risk patients with the SAPIEN valve. And here again, if you look at death from any cause, there's no P value here, but you have a hazard ratio of 0.41. So again, it shows that TAVR is better than surgery. And here, if you take the high risk, intermediate risk, and low risk randomized trials together, all those 7 trials, you see that all the trials have shown that it favors transcatheter valves as opposed to surgical aortic valves. Especially if we look at my topic, the low-risk patients, the PARTNER 3 and the Evolute low-risk patients favors transcatheter valves if you look at cardiovascular death. Now, it was always a big issue about long-term durability. When the transcatheter valves came up, everybody said they will not last. I don't know why anybody would argue that they do not last, or that they last less than the surgical valves, but that was a big issue in the beginning. So let's have a look. We have so-called long-term studies up to 7 and 8 years, also from my department, and you see here bioprosthetic valve failure is about the same as you would see it for surgical bioprosthesis. So at least up to 8 years approximately, we can say there's no difference in long-term durability or in valve degeneration up to this time between bioprosthetic surgical valves and transcatheter valves. Now, another argument for transcatheter valves was they produce less patient prosthesis mismatch. Now let's have a look. Here's a big study on 62,000 patients from the SDS and TVT database. And first you see in the cake-shaped chart that 63% of patients with transcatheter valves have no patient prosthesis mismatch, 24 have moderate, and only 12% have severe patient prosthesis mismatch. And on the right, you see the mortality with patient prosthesis mismatch, and you see that none and moderate patient prosthesis mismatch has no influence on mortality. However, if you have severe patient prosthesis mismatch, you have an influence on mortality. As I said, this is a strong study, came out in 2018 on 62,000 patients. It looks just as at transcatheter valves. Now, if we look at the studies, we have a very diverse picture. In the core valve high-risk study, for example, you did not see a significant difference for the surgical patients and for the TAVR patients if you analyzed them alone. Only, and this is the lower graph, only if you put the SAVR patients and the transcatheter patients into one analysis, then you have a significant difference in mortality between patients with patient prosthesis mismatch and patients without patient prosthesis mismatch. In the Partner 1A trial, this was a little bit different. I remember those are high-risk patients, Partner 1A, and here you see for the surgical patients, you see a significant difference in death if they have a patient prosthesis mismatch, and you do not see that difference in the patients with transcatheter valves. In the end, if you take those 4 big studies, Partner 1, core valve high risk, Partner 3, and Evolute low risk, all together, the only difference, significant difference, you see in the 2 studies with the self-expanding valve, there is significantly less severe patient prosthesis mismatch in patients who receive a self-expanding valve, here marked with a star, as opposed to patients who receive a balloon expandable valve. Another big issue is aortic valve insufficiency, paravalvular leak, that we as surgeons do not know actually, and this whole issue came up with the application of transcatheter valves. However, with the new generation devices, and this is shown here in the Partner 3 data, you see on the right side 30 days and 1 year paravalvular leak in surgical valves. And in surgical valves, you see there's 97% no paravalvular leak and only in a very, very low percentage a mild paravalvular leak. In the transcatheter valves, still you have in about 70% now with the new devices, no paravalvular leak, and about 30% a mild, and the moderate paravalvular leak, which is significant for mortality, does almost not exist even with the new generation transcatheter valves. The same you see here in the Evolute low-risk trial. If you focus on moderate and severe in the lower panel, you see there's almost no difference between surgical and transcatheter valves. However, if you look at none and trace, you see a significant difference between transcatheter and surgery. So there's no doubt you have more paravalvular leak in transcatheter valves, but it doesn't seem to be severe anymore, and therefore it shouldn't affect mortality. Here again, from the Partner 2 study, it shows that only patients with moderate or severe paravalvular leak have a higher mortality. Those are only patients with transcatheter valves. Another big issue was stroke. In the beginning, the stroke rate was fairly high in the patients with transcatheter valves. Let's have a look how it is now. Those are the low-risk trials, Evolute low risk and Partner 3 low risk. And you see here, there's only one difference in the Partner 3 study with the entity any stroke. In any stroke, the transcatheter is somewhat or significantly lower than the surgical bioprosthesis. In disabling stroke and non-disabling stroke, there's practically no difference between surgical and transcatheter valves. And you see this here again, any stroke and disabling stroke for all the studies, the randomized studies that have been done. And in all those studies, TAVR is favored and has not always significant, but it has a tendency to show lower stroke rates. As you see here, Evolute 3, Evolute low risk and Partner 3, and again, Partner 3 and Evolute low risk both displays a lower stroke rate than surgical valves. How about pacemaker? Pacemaker is a big issue, especially if you want to move forward to lower risk and younger patients. There have been some changes. The new SAPIEN 3 initially has had a little greater pacemaker rate. The Symetis Accurate had some less, and the core valve came down with the Evolute from 26 to 17%. Now, in the randomized trials, in the Evolute R low-risk trial, there was 17.4% for transcatheter and 6.1% for surgical valves. In the Partner 3, you had 6.5% for TAVR and 4% for surgical valves. Now, just recently, in 2019, there was an interesting paper coming out, and they started to measure the length or the plane of the interventricular septum in CT images. And they tried to implant according to the size of the septum, meaning that as long as you do not reach the lower part of the septum with your transcatheter valves, you shouldn't have a block. Here are patients with a membranous septum, MS, stands for membranous septum, of more than 5 millimeters. And if you have a low implantation depth below 5 millimeters, then your pacemaker rate is only 1.9%. Those are patients with a membranous septum of 2.2 to 5 millimeters. And again, if you stay below this limit of 2 to 5 millimeters, then you have a low risk of 2% of pacemaker rate. If you go further down, you have already 10% pacemaker rate. And those are high-risk patients with a very small membranous septum of only 2 millimeters. And again, if you can manage it to implant your transcatheter valve very high, you have only almost no pacemaker rate. If you implant in those patients too low, you have more than 20% pacemaker rate. So all I want to say with this is that you can modify by implanting higher or lower, you can modify your pacemaker rate. And the authors concluded that you could reduce the pacemaker rate from an average of 9.7% to 3%, and 25% you can reduce left bundle branch block to 9%. Now there are a lot of other things like kidney failure, then new onset atrial fibrillation, major bleeding. They all, in the randomized trials, they all favor transcatheter valves. Only you have more vascular complications and a high incidence of valve endocarditis in the patients with transcatheter valves. So what is left for surgery if you look at the transcatheter valves as aggressively as I just did it? There are heavily calcified bicuspid valves, especially in young patients. I would not recommend to treat those with transcatheter valves. As you see here, a deformed core valve, you have a risk of rupture, and I think those patients are better off with a surgical operation. If you have concomitant aortic disease, especially also in bicuspid patients with aneurysm, of course, you go for surgery. And absolutely clear is that endocarditis is still a field for surgery. Now, let's conclude. The first heart teams we saw, I would call it heart team 1.0. Most patients went to surgery, and a few patients were considered for transcatheter valves. Patients with high age, patients with high risk scores. Now we have the low risk studies out, and now we can see that most patients in the future will probably go to transcatheter valves, and only a few will be considered for surgical aortic valves. So the old battle between cardiologists and surgeons may come to an end because the only way we can, as surgeons, react to this is to work together with the cardiologist in a heart team, and this should look like this here. If everybody works together, it's a smooth and fast procedure, and very, very good, certainly, for the patient. So my point of view would be TAVR for almost all. Thank you.
Great. Thank you very much, Rüdiger, for your excellent review and summary of this topic. Well, we have different topics for each speaker's this session. The topic would be open for discussion. If there is a comment or questions from the floor, please identify yourself and ask. Well, this morning I asked Anthony to talk about surgical side for his statistical data. Please, Anthony.
Thanks, Björn. So Rüdiger, very nicely done. I would say there's one more thing that favors TAVR, and you don't have it on any of your slides, and that is that there are about 10 times more cardiologists in the world than there are heart surgeons, and there's about $6 billion more on the TAVI side to try to prove that it's better than surgery. And I think those two things really sway the argument, and that's what starts to sway the argument. The second thing is we really need to know, when you present these data, what groups you're actually looking at. Because, Rüdiger, you spoke about isolated aortic valve replacement. None of the trials that you listed were trials of isolated aortic valve replacement versus TAVI. Not one of them. And so the cardiologists and the medical industrial complex that's putting this forward has put it forth as a trial of isolated SAVR against TAVI, but that's not the case. And so we've extrapolated what they've said. We also have to look at the groups. Like what group are you talking about? Are you talking the intent to treat group, the as treated group, or the valve implant group? And when you start to dig down into those data, the data start to change. So tomorrow morning, we're going to look at, when we dig into the data of the publicly available data for Partner 1, how the data have changed. Unfortunately, Partner 2, Partner 3, Evolute 1, Evolute 2, none of those data are publicly available, and they're owned by the companies. And so what comes out into the press are all the positives for TAVI. That's their job. But what we don't know is how to use only positive data for patient selection, which is what you've done and what everyone else is doing. But we need to know both the pros and the cons. For example, if there's so much less PPM, patient prosthesis mismatch, with TAVI than with surgical aortic valve, then why is it that surgical aortic valves have better reverse remodeling by a significant amount than TAVI? And if there is so much less aortic insufficiency now, why is aortic insufficiency still a predictor of death? And why is aortic insufficiency not a predictor of death in the surgical population? So these are two inherently different operations. And I think what we as surgeons have done is allowed us to make the mistake of assuming that everything we are told is the complete truth. It's the whole truth. And we haven't been told the whole truth. So I'm urging a step back and a look at the data rather than just rolling over on our backs and saying, oh, you're right, our specialty has changed forever. It may be changed forever, but we need to actually look at the real data. And we're blinded to the real data. You are, everyone is. I'm partially blind to it because I took the time to read some of the data that was turned into the FDA. But I do think the jury's out. And the last thing is, in terms of low risk, we have to remember, if we're going to extrapolate a trial to the general population, we can really only extrapolate it in a similar population to who was in the trial. Now, the average age in the Partner 3 study was 74. So because it's a good thing, or even in the intent to treat group, who all didn't get surgery and who all didn't have isolated valve surgery, even so, in that group, to take that analysis in it with an average age of 74 and apply it to a 45-year-old man is incorrect. And we have to be the ones to stand up and tell that to the cardiologists, because to them it doesn't matter. So we have to actually understand the data to speak thoughtfully and intelligently in a heart team meeting, and we have to be willing to stand up and brave enough to stand up and speak the truth. And I think when you start doing that, it's not all TAVI. That's my opinion.
Just a brief comment, because we could discuss this all day. Yeah, your first point is well taken. There's an incredible economic power between the whole TAVR industry. And as it is always in life, if there's economic interest, then the data may not be as true as we think they are. So this is a point that is absolutely taken. You just have to look at what I said about the Partner 3 trial. To make it better than surgery, they put in as an endpoint stroke, death, but also rehospitalization. I mean, what does rehospitalization have to do as an endpoint in such a trial? Now, that the surgical patient may have to go more often to the hospital in the first year after the operation is quite clear. But this is one simple way of making a real difference. Now, on the other hand, and I also talk on the basis of my own experience. And we just, in my surgical department, we have implanted more than 3,500 transcatheter valves in the last 12 years. I'm absolutely convinced that, for example, paravalvular leak is down to none or maybe mild, not more with the new prosthesis. because we do it every day and we see it. And there are a lot of patients now leaving the OR without any paravalvular leak, regardless of whether you take a Sapien or Evolute, a little bit more with the Accurate, but there is a tremendous improvement in this. And patient prosthesis mismatch, you also have patient prosthesis mismatch, of course, in surgical patients. And it has been shown long before TAVI came up that the mortality is higher in patients with severe patient prosthesis mismatch in the surgical group too. So this is not really a big difference. However, if today, if you have a 60-year-old woman with an annulus of 18 or 19 millimeter, there's nothing wrong to put in a transcatheter valve, because she will have a much lower gradient than with a 19, or maybe if you enlarge the annulus a little bit, a 21 millimeter valve. So in the end, I cannot debate everything you said, because you were right in a lot of things. However, I'm 66 years old now. If I needed aortic valve, I would choose the transcatheter valve.
It's really funny because I'm 61 and I'd pick a pericardial, like a Magna, and I've looked at the long term. And the other thing that comes up is that you didn't bring up, of course you wouldn't, and I understand that. It's a great talk, but in partner 2, there's a divergence of the curve starting at 2 years. So the long term looks like the long term survival, at least in the intermediate group, beyond 2 years is favoring surgery. And Vino Thorlani, who didn't quite make it to the meeting, has those slides, and they're made publicly available. But it looks like the curves are starting to diverge. So I think there may be a longer-term survival advantage for our patients, and I think it's going to end up much like the coronary bypass versus PCI argument, where PCI looks great right up front, and then the curves start to diverge later. And we're going to have a conversation with our patients about early versus late survival. But I think we need to know all those data to have an intelligent conversation of informed consent with our patient population. And don't get me wrong, I do TAVI every week. I think it's a fantastic procedure. And the day after we do TAVIs on Tuesday, and on Wednesday I'm walking going, why? This is an awesome operation. But it's not about the hospital stay. It's about the long-term outcome and what's going to happen long-term. So we have to remember that. It's a lot easier to do a TAVI than it is to do an aortic valve replacement. We all know that. And it's a lot of fun. But I think we need to take a step back and really look at the data and apply it to the appropriate patient populations. That's all I'm making an argument for.
No, your point is well taken, but let me just tell you one more anecdote. You all know this famous paper by Michael Mech, The Crossing of Fortunes. And this paper has been published in the 90s, and he has shown that PCI has surpassed bypass surgery already in, I cannot remember it exactly, I think 95 or so. Since then, we have hundreds of really big studies showing that bypass surgery is better in long-term mortality, better in re-intervention, better in all aspects. And what do you see today? Bypass surgery in Germany went down by 10,000 last year, although all those studies are on the market. So we should be critical, but if we start to fight it, we will lose. We can only play with the group as a team.
Okay, Dr. Guri, just a short comment or question, please.
Really short comment. It is about the training of the new generation of cardiac surgeon. You know, when we look to the last slides, that the patients left for surgery are bicuspid, endocarditis, aneurysm, all those things. I mean, in a teaching center, if in 10 years your cardiac surgeon doesn't have patients for surgical aortic valve replacement, how can he face, or how can he do the complex case? How can he face the complications of TAVI? we have no, I mean, when we are looking to this, let's say, trends of TAVR versus surgery, I have some fear that our new cardiac surgeon in 10, 15 years maybe will not be able to face the new patients, let's say, or the patients left for surgery, or the complications of TAVR. You have for 12 years now, you are performing TAVR. Can you tell us a little bit about the complications of TAVR, the redo of TAVRs? It is a simple case. Can our new trainee in 10, 15 years, can he face, we have our experience now. I mean, we are expert surgeon in aortic surgery, whatever, so we can face all kinds of problem. But how a new surgeon, or young guy, in 10, 15 years, can he face those problems? Can you comment on that?
You mean problems with the TAVR procedure or with the surgical procedure?
No, TAVR, he can do it, because maybe 90% are TAVR, but on the surgical place. I mean, a guy who is doing all the time TAVR, he doesn't have any experience in simple, single aortic valve replacement, because all the cases are done by TAVR. So how a young guy, only experienced in TAVR, can face the complex situations?
I think this can only be done by minimizing the number of surgeons, because, and you see already a change in surgery right now. You and my generation, we had time enough, we worked day and night, and we had time enough to learn almost all procedures. Until last year, I did also the whole pediatric operations in our hospital. Today, my staff, they are already subspecialized. I have some surgeons who do only mitral valves, some do only aortic root and aortic reconstruction, some do only assist devices. So there is already, I don't know how it is in your units, but in our unit there is already a subspecialization.
Yeah, okay.
So now in a couple years, if they have even less experience, there will be very, very few surgeons who may still be able to do all the surgery. But it is a big issue, I agree with you.
Okay, we have a limitation of time, so we passed 30 minutes already. So we have to move to the next topic. Please. Okay, it's a great discussions for this early morning session. And Scott Rankin gonna talk about severe ischemic MR, repair versus replacement for his on the side of replacement. Dr. Scott Rankin, please.
Well, again, thank you for the privilege of presenting today. Can we make sure the voice is on? The voice track is on. I'm showing some videos with voice. So turn the voice on.
Is there any problems? Or if we take some time, so we can move to the, okay. Dr. El-Khoury, you're gonna use your personal laptop computer. Okay, so prepare for him. Thank you very much.
Great, that'll work. That's not right. That should work. Okay. My charge today is to discuss mitral valve repair versus replacement for ischemic mitral regurgitation. And I really appreciate being invited to do this. The subject has come up again since these CTS network studies. And you can see here 2-year outcomes with the mitral replacement in red having a higher early mortality, but the mortality is equalizing over time as the repairs in blue fail. And we all understand what the problems with these kinds of trials are. They're underpowered. There's not enough, really there weren't enough patients in these trials to do a mortality analysis to have the power to do it. And a third of the patients, the repairs failed. We know how to make a repair for ischemic MR work, and the surgeons weren't trained to do that. Some of them weren't. And so we end up with this kind of problem, and it really is a function of poorly designed clinical trials. I'm pretty down on clinical trials anyway, but this is an example of the problems you can get into with one. And so I'll just show you my view of ischemic mitral regurgitation. Is mitral regurgitation precipitated by myocardial infarction with essentially normal leaflet and chordal support. There are several faulty concepts circulating. The MR is usually caused by myocardial infarction rather than reversible ischemia. Surgical repair provides a significant survival benefit, and as I'll show you, ischemic MR involves more than a ventricular problem. In fact, mitral valve competence requires the integrated function of all 5 aspects of the valve: annulus, leaflets, chordae, papillary muscles, and ventricular wall. And as in George Birch's classic 1966 papillary muscle dysfunction paper, most cases involve predominant annular dilatation, as in the upper panel, but others experience leaflet tethering due to infarct expansion, as on the bottom. And rarely, papillary muscles can elongate or rupture, producing leaflet prolapse. In reviewing our cases at Duke in the 1980s, 3 patterns emerged. Most patients had type 1 with limited posterior wall infarcts and papillary muscle dysfunction syndrome. Rarely in type 2, papillary muscles were elongated or ruptured, usually with small infarcts, most often of the anterior papillary muscle, and preserved ventricular function. And finally, type 3 patients have burned out infarcted ventricles, and if 2 of the 3 regions are fully infarcted by viability testing, we would consider transplantation rather than valve repair. Mark Hickey, who is a consultant at Leicester now, spent time with us in the 1980s and showed in the Duke Databank that increasing levels of IMR progressively worsen prognosis, whether assessing raw data on the left or risk-adjusted survival on the right. Because of poor results with valve replacement in the 1980s, we started repairing more valves, and by 1990, with a sample size of only 51, we could show better risk-adjusted survival with repair as compared to replacement in these acutely ill patients. This occurred primarily because of a lower operative mortality, but also the long-term survival was better. But notice the 15 to 20% better long-term survival at the beginning of our experience. Because of better results, we started repairing more IMR as the decade progressed, and although the individual mortalities for repair and replacement remained relatively constant over the period, the overall mortality fell dramatically because of increasing use of repair. Thus, by 1990, the overall mortality for IMR was 10% and 7% for repair, good results for the time. So the common type of ischemic MR involves the posterior wall, usually is caused by right and/or circumflex coronary infarcts, produces moderate posterior lateral LV dysfunction, and usually will not reverse with revascularization alone. As we described in the 1980s, the decision to repair the valve should be based on the appearance of moderate or worse MR on the intraoperative transesophageal echo, sometimes with provocative volume loading from the pump before bypass. Posterior annular dilatation is an important mechanism of ischemic MR and should be corrected with a true-sized, full rigid ring, and I still use Carpentier's original design. As Craig Miller's laboratory has shown, fixed reduction in anterior-posterior annular geometry is extremely important in this entity. These patients often have minor leaflet abnormalities such as fetal commissural cusps or clefts, predisposing them to opening up the valve with ischemic posterior annular dilatation and often requiring cleft closure. Occasionally, leaflets can be tethered by infarct expansion, contributing importantly to lack of valve closure. And as Frank Langer showed in Craig Miller's lab, a posterior leaflet autologous pericardial patch can be used to compensate for the tethering, providing a large margin of safety long-term if further geometric changes occur. For leaflet prolapse due to elongated or ruptured papillary muscles, Gore-Tex artificial cords are placed to a viable papillary muscle, adjusting cord length after ring replacement as we have described. But from Don Glauer's and my combined series, it is now clear that the generally poor prognosis after repair for ischemic MR, with a 56% 5-year survival on the left, is due primarily to advanced age and adverse risk factors which are characteristic of this disorder. And if these are taken into account with the Cox model, valve repair restores these patients to an adjusted survival that is similar to repair for degenerative disease. Thus, IMR patients achieve as good results with repair as any other etiology, and the raw survival is lower because they are older with more adverse prognostic risk factors preoperatively. The first patient is a 77-year-old man experiencing an acute circumflex infarct that produced acute moderate to severe MR and congestive heart failure. On TEE, you can see loss of valve coaptation at the posterior commissure due to annular dilatation from a large posterior lateral infarct. This produced the characteristic loss of coaptation area and central MR jet, but both leaflets are at the annular plane and not tethered or prolapsed. After simple insertion of a full rigid ring, the valve is entirely competent. Patient 2 is a 55-year-old obese diabetic who experienced a right coronary infarct 6 months earlier, which was treated with stenting, but MR and heart failure persisted at a moderate to severe level. She now has an in-stent stenosis in the RCA and also an LAD lesion, and her ventricle shows residual of the inferior infarct with additional dilatation. There is loss of central mitral coaptation due to annular dilatation and a hint of tenting and leaflet tethering, and moderate to severe MR with a central jet. When the valve is inspected, though, the posterior leaflet seems fine with good closure and minimal tethering on valve testing by ventricular distension with cold saline. Therefore, the valve is repaired by simple placement of the Carpentier ring with good recovery of competence and no residual leak. So most ischemic MR can be repaired with full ring annuloplasty alone with a low reoperation MR recurrence rate as documented in our series. The next patient is a frail elderly female presenting with an acute circumflex infarct and severe MR not resolving with PCI. Unlike the first two patients, she had posterior leaflet tethering. She had severe LV dysfunction, mainly in the lateral wall, due to the infarct. Here is the occluded circumflex coronary artery, and also notice the LAD lesion. The circumflex was stented, and she also had a right coronary lesion. But the MR and heart failure remained severe. Again, we like CMR viability studies and will operate if 2 of the 3 regions appear viable. In fact, she seemed to have good residual myocardium everywhere. Upon inspecting the valve, the right aspect of the posterior leaflet was tethered, and we couldn't get it to coapt even with saline distension. And here you can see the posterior leaflet pulled down into the ventricle with tethering from infarct expansion. A glutaraldehyde fixed autologous pericardial patch was inserted into the posterior leaflet to compensate for the tethering, and most of what you see here is patch, with the posterior leaflet moving down into the ventricle to become the entire coaptation area, and with excellent recovery of confidence. Surface echo obtained 6 months postoperatively shows good valve opening and only trivial residual leak. The next patient is a 57-year-old man who had a major right coronary infarct producing severe MR, a posterior LV aneurysm, and severe heart failure. His right coronary was occluded proximally, and he also had LAD disease. In addition, there was a large posterior wall aneurysm. The aneurysm was resected and closed primarily, approximating viable aneurysm edge to viable edge, and removing all acontractile scar. I think it is a mistake to insert patches, and I like to primarily close all aneurysms. Upon inspecting the valve, he had a chronically ruptured posterior papillary muscle at the posterior commissure with severe prolapse that was not appreciated on the echo. A 2L Gore-Tex artificial cord was placed to a viable papillary muscle and stuffed into the ventricle for later retrieval. After ring placement, the cord was woven into the prolapsing segment and the length was adjusted. And as you see here, the valve is nicely competent with no residual leak. The next patient is a 71-year-old man who had coronary bypass during a major right coronary infarct in the 1980s and presents now with severe ischemic MR and TR along with moderate aortic valve disease. All 3 valves were repaired. The mitral has the typical appearance of ischemic MR, and here there is just a hint of leaflet prolapse at the commissure. Upon inspecting the valve, he had elongation of a posterior papillary muscle to the commissure, producing prolapse of the right aspect of both leaflets and the commissure. And here 3 cords have been placed and the valve is competent, with mild residual leak because the posterior cord was a little short, but overall good results. The last patient is a 61-year-old man with a remote coronary bypass for an inferior MI and severe persistent MR due to both posterior leaflet tethering and anterior leaflet prolapse, the only patient I've had with both. Here you can see the posterior leaflet pulled down into the ventricle and a segment of the anterior leaflet prolapsing, producing 2 separate jets of MR. The posterior leaflet is especially evident here. And with a patch to the posterior leaflet and a cord to the anterior leaflet, we got this one just right with good leaflet position and no residual leak. And here in A is the posterior tethering, in B is the anterior prolapse, the double jets in C, and no residual leak after complex repair in D. Finally, I'd like to discuss our most recent paper published in Annals of Thoracic Surgery in 2008. Now with 20 years of data from 1986 through 2006, we looked at 4 groups in the Duke practice. Group 1 was 16,209 coronary bypass patients with no MR. Group 2A included 3,181 patients with mild to moderate MR treated with coronary bypass alone. Group 2B was 416 patients managed with mitral repair, and Group 2C was 106 patients receiving prosthetic mitral valve replacement. This is a very strong study because it is the largest series in the literature. It has the longest follow-up. It used contemporary multivariable statistical analysis with a Cox model, and the Duke surgeons, for the most part, used a consistent repair technique over the entire 20 years, that is, full rigid rings. Raw unadjusted survival is shown in the top panel for standard coronary bypass in blue on the top, coronary bypass with mild to moderate MR in pink, moderate to severe MR treated with repair in green, and valve replacement in brown. With risk adjustment in the lower panel, repair patients achieved 94% of the survival prognosis of standard coronary bypass, and replacement averaged 15% lower survival over the 15 years, data that are very similar to those observed in our first 51 patients. If the augmented ejection fraction produced by MR preoperatively was taken into account in the analysis, in fact, repair restored the patients back to a prognosis equivalent to standard coronary bypass, whereas valve replacement still achieved markedly inferior results. So in conclusion, the pathophysiology of ischemic MR can be complex, with aspects involving the annulus, leaflets, cords, papillary muscles, and ventricular wall. Validated repair techniques exist for each of these problems. Mitral repair should be the uniform procedure of choice for moderate or worse ischemic MR. And finally, repair restores patients to a prognosis equivalent to standard coronary bypass for a given patient's age and comorbidities. Thank you.
Dr. El-Khoury, are you ready to present your topics for this title? Okay, yes. So we're going to have discussions after Dr. El-Khoury's presentation for this session.
So I had some problem with the program, so for why I will present only to you two videos. Scott, I mean, you replace any valve. You should repair all the valves. So yeah, okay, yeah. So I don't know what to debate. Anyway, let's go for the first patient. This acute severe aortic regurgitation. You can see this lady, 63 years old, came to us for severe mitral regurgitation. And you can see here that we have really the real aspect of severe mitral regurgitation, the posterior jet. And if you look to the angiography, you have only very small, very short occlusion of the PDA. Really very, very short segment. You can see the distal part of the PDA is occluded. And this lady, so that's what we've done at the surgery, is very, very short graft, coronary graft from PDA to PDA with a short piece of vein. But look what we had at the you can see that one head of the posterior leaflet was ruptured. We have severe acute mitral regurgitation. Should we replace or repair? We always try to repair. You can see here that is the head going to the commissural part, and the other part is going to the A2, A3. So what I start to do is really approximate, close the indentation, let's say the commissure between the anterior part of the posterior commissure and A3, resect the papillary head of the going to the commissure. That's because it is really very fragile and we cannot re-implant it. Close totally the commissure between A3 and the anterior part of the posterior commissure. And this is really, the valve looks normal, and the part of the papillary muscle ruptured one is really quite solid. You will see it. So we close the first part. Now that's the papillary head going to the anterior. And it was quite solid. The fibrous part is still there. So what we've done, what we do usually in the homograft implantation of the mitral valve, the papillary muscle to papillary muscle suturing side to side with the 4-0 supported with the Teflon. That's the head of the papillary muscle, the intact one going to P3. And we really re-implanted this commissure. So this papillary muscle, sorry. This papillary muscle suturing. we can argue that this suturing is quite fragile, and maybe we will have a rupture later on. So in order to avoid that, you will see, in order to avoid and to decrease the tension and the stress on this suturing, what we do is take a Gore-Tex. You can see here that the valve is already repaired, more or less. Now we take a Gore-Tex on the posterior leaflet, on the posterior head of the papillary muscle, and we anchor it on one side on the papillary muscle, intact one, and the other side on the free margin of the of A3 and the commissure. So you have the implantation of the commissure, and we have some kind of reinforcement with Gore-Tex in order to retrieve the pressure, the tension, the stress on this implantation. And for sure, we finish this surgery with the ring. That's the first one. Look at this patient now. It is a chronic one. And you can see here we have really the typical aspect of severe chronic mitral regurgitation, ischemic one. We have a type 1 dilated annulus, and we have here the restrictive part of P3 and the typical aspect of eccentric and deformation of the annulus. You check everything, the papillary muscle, the chorda, the annulus, and you can't find anything. So you are really, that's our situation. I mean, when we are facing severe chronic mitral regurgitation, what to do? Only ring? Or, I mean, yeah, we have a lot of not a lot. We have, let's say, we ask ourselves what to do in this situation. You can start to review all the pathophysiology of the mitral regurgitation. You have in mind the all surgical aspect, ring, papillary muscle relocation, imbrication, Homburg string, second chorda cutting, Fontan stitch, door patch, what to do in this situation. And that's really the real situation, let's say, in the OR. And I have this patient 1 month ago when I saw that I have something I have to debate here. The problem, in my opinion, when we replace the mitral valve, the result, the reproducibility of the technique is always good because I mean that there is nothing to do. We replace the surgical techniques usually is perfect, and there is absence of mitral regurgitation or whatever. So technically, replacing the mitral valve is quite easy. While if you want to repair this valve, that's really the problem, and you have to combine a lot of surgical techniques. But in my opinion, and we are not really always focusing on that, is how you can see the many surgical techniques described. You have all those in mind. But when you are in the OR, you start thinking and doing what to do. So I'm examining everything. We have time, the heart is arrested. We have a good cardioplegia. And you try to see what to do in this situation. Should we work on the ventricular side? Should we do only on the annular side? You start by, it is not edited, this video. It's exactly what we do in the OR when we are facing the severe mitral regurgitation ischemic one. I try to individualize the papillary muscle. The papillary muscle are displaced from each other. So one thing which is really very important is look at this stitch for the implantation. And I think we don't insist as a cardiac surgeon on that. One of the reasons of failure of the ring implant annuloplasty in ischemic is the quality of the stitch on the posterior part, mainly on P3. some cardiac surgeons put this stitch mainly on the atrial wall, and for sure, when you tie this ring, the mitral annulus remain in place and without any anterior displacement. So it's really very, very important to your stitch should be well done into the annulus, and when you pull on those stitch, you should really have all mitral ring with you. Now I'm trying now to see how we can extend it P3. That's you can separate here as described by Scott, and you can put the pericardial patch over there. I'm thinking about that, so I said to myself, well, no, it is too fragile. Don't do the patch, because sometimes you will have a dehiscence or whatever. I sought to reapproximate the papillary muscle. So I separate some adhesions between the papillary muscle and the ventricular wall. Now I'm thinking about Schaffer's technique. Bring up the papillary muscle towards the trigone. I said, well, maybe it is not necessary. On the other papillary muscle, there is no displacement over there, so I said, no, don't do that. You know, I'm really hesitating which technique I have to use. I thought about cutting the secondary chorda, advocated by Tyrone David. And I remind why my former boss, Dr. Dion, used to tell me, if you cut this one, the secondary chorda, you have to go to jail. So I said, no, don't cut it. Look at it, don't cut it. So that's really the real situation when you are facing ischemic mitral regurgitation. You think about all the techniques. Yeah, that's the secondary chorda. I will find it. It is a good one. I asked my nurse to give me the knife, and I said, no, don't give me. I leave it. I don't want to go to jail. So at the end, you can see now, you will see I approximated the papillary muscle. You see that? You can approximate the posterior to the anterior, do some approximation using the Proline or whatever supported with Teflon. You will see that I was about to do that. You know, I repair everything. I really individualize the papillary muscle. That's let's say, the real situation in the OR when we are facing this. Yeah, it is free now. The second one is also free. And I said, well, give me Proline 40 with the Teflon in order to approximate this, or you can put a band around that. So I said, no, don't give me anything. I will continue with other hesitating. That's the way you can really do that. So after many hesitations, I told my nurse, scrub nurse, give me the Ticron or Etibond. I will do only a ring. But this ring should be, the stitch should be really very, very solid. And you can see how it is not really simple to put a ring, mainly in ischemic one. So really the stitch should be well done into the mitral annulus. And when you do your water test at the end, you will see. If you have 1 minute, we have still 2 minutes to for the videos. So I will continue only with the video. You will put the ring, and I ask for the water test. And I think it is. The water test should be really well done in ischemic. You have to really feel completely the ventricle, and you can pull on the posterior annulus. I'm sorry, well, my head. No, yeah, you can see that I'm pulling on that, and this stitch is a solid. There is no tear over there, and if you are, and the anterior leaflet is only covering the whole orifice. The posterior, we cannot see it even. So when you are sure that you can really cover the whole orifice with the anterior one by pulling on the stitch, you put your ring. You size and you put your ring, and you are sure that these patients will not have any recurrence of mitral of MR because the ring is well in place. So repairing the mitral valve in severe ischemic mitral regurgitations, we have a lot of surgical techniques described, but we have to really consider the most frequent one, the ring implantation, and try always to implant it in the right way, very stable stitches, and in the majority of cases, you will see the water test after the ring, in the majority of cases, you don't need more. So learn how to implant the ring in ischemic mitral regurgitation is, I think, the cornerstone of the mitral valve repair. You have a lot of techniques in your mind, but at the end, putting a complete ring in the right way and stable way will solve the majority of problem. As you can see here, I will show you, if you have 10 seconds, to see the water test and the cooptation of this. So the anterior leaflet is covering the whole orifice. No MR, even when your left ventricle is really distended. And you can see here that we have more than 8 millimeters of cooptation, 8 millimeters advocated by Leiden group. Thank you for your attention.
Yeah, thank you very much. We have only little time to discuss. I have one question. There are profiled rings, specialized profiled rings, where the posterior part of the ring is lifted up. Why didn't you choose a ring like this?
I mean, my personal experience, I don't like all the 3D ring. I will explain to you why. I mean, we are used to our stitches are so solid, and we don't, no, and in other words, the 3D needs a lot of stitches. So if you are not using a lot of stitch, you will have dehiscence. And I had this experience with all 3D in ischemic one. I think you have to change your way to implant, to put your stitch if you want to use all the high profile or 3D ring on the mitral valve. So for why I prefer really the simple one, but having very, very, very solid stitches. That's my approach. I mean, I used all the rings, but I had some technical problems in terms of dehiscence of the stitches when I have this 3D mainly on the posterior, but the anterior is okay. For why I stop it.
So you both showed repair. There's a whole bunch of literature out there that shows that repair fails after 1 or 2 years if you just repair with a ring.
Yeah.
And so now you show that you can treat those valves initially, but everybody knows that you can treat them initially. So what's about the long term?
That's I want to show only repair because I thought that Scott will talk about the replacement. What I want to say, to insist on, to emphasize that we should really, we should insist on the way we implant our ring. It is really, as a cardiac surgeon, I saw a lot of different way of implantation of the ring, which are so fragile. We put only the ring into the left atrium, all those things. And I think if you compare the result, we will have a recurrence. So for why I insist for having really the standard technique of implantation of the ring, and after we can discuss about the recurrence. For sure, we will have some recurrence, and I will replace the mitral valve in some situation when we have a really the tether incline is more than 1 centimeter or 2 centimeters. If the left ventricle is so diseased, so if the life expectancy also is really very short of the patients, I don't hesitate to replace the valve. But in the majority of situations, I think as a cardiac surgeon, as we should insist on the way we are implanting our ring, because it's, I think, one of the big reason of failure of our mitral valve repair. That's my conviction.
I have a question for both of you.
Yes.
Could you please help us all understand what was invalid or incorrect about the randomized trial by Acker and CTS-NET, and basically who showed that the survival was the same, the mortality was the same, everything was the same except for recurrent MR.
Yes.
At about a year. And then to me, it's also in ischemic MR, you know, the average survival for ischemic MR is only about 8 years.
Yes.
So we're not looking for a super long-term operation. Scott, your long-term follow-up was out to 12 years, and it looked like the survival, the post-operative survival curves diverged at about 3 years, if you just include post-operative survivors. So help us make sense of, please, both of you, what to make of the CTS trial versus this. We all know, yes, we can repair it, but it's not about being able to do it, it's about the longer term. Help us understand.
Well, the thing that disappointed me about that trial is my good friend Irv Krohn was the head of the trial, and he'd written 10 papers in the preceding decade on the importance of managing tethering of the leaflets in ischemic MR, and it wasn't applied to that population. And they evidently, maybe those in the room that participated, evidently they just left every center to do whatever kind of repair they wanted. And I think it's clear, and this goes back to Duran's first paper, it's clear that if there's tethering of a leaflet, something's got to be done. And I like to use the patches, but you've got papillary muscle translocation, and then Schaefer's ring and string that works well. And I think if you do those techniques, the recurrence rate's not going to be high. In our series, we had a 9% recurrence rate treated medically and 2% reoperation rate over the long term. So the whole problem with that trial is that they didn't manage the tethering of the leaflets, and if you've got a patient with tethered leaflets or some of these other problems, they need to be managed. You just can't treat those just with a ring.
My problem, I don't know what is with the ischemic mitral regurgitation, that in my institution, I do around 150, 160 mitral valve repair a year, and I have maybe 3-4 ischemic mitral valve regurgitation. The problem that we don't have enough now patients to really make a lot of studies in our department. One of my young colleagues, cardiologist, tried to do his PhD on those patients, but we didn't find them. He spent 2 years, and he had only 7 patients. It's not as frequent as we believe. So that's my first comment. So I don't really can give you my proper experience. The second, I am not saying that we have to repair all the valves. Some patients, when, as I said, with really very short life expectancy and whatever, is much more easier to replace this valve than to repair it. But again, in our discussion as a cardiac surgeon, I think the way we implant, we do our job is really very, very, very important, and we should really insist on that. That's my opinion.
Well, I got into this in the early 1980s, and when Duke bought the helicopter, and any CCU that had a patient in the state that had acute ischemic syndrome could be transferred in 15 minutes, and all of a sudden we started seeing all these people with ischemic MR, and we didn't know how to manage them. We were doing valve replacement, and the mortality rate was high. It was high at Penn. It was, I mean, that data are out. Those data are out there, and it really helped when we converted to repair. We were following actually the Jerry Kay's lead on that, if you look at the long-term outcomes, if you manage the tethering properly, they're very, very good. We just did a paper last year in Annals of Thoracic Surgery looking at etiology of mitral valve disease. I would recommend you look at that. The mortality rate for mitral valve repair and ischemic MR in the United States is 6%. And I think that's very good. It's equivalent basically to what we achieved by 1990 by converting to repair. 2/3 of the cases are repaired in the US. The mortality rate for mitral valve replacement in ischemic MR, what do you think it is in the US? 15%. And that's the same data that we saw back in the 80s, and I think the world hasn't changed. And we need to focus on doing a good repair and a complete repair that's going to last rather than switching to valve replacement, because that's not, the outcomes with that aren't very good.
I had a patient last month, really very fragile patients. The mitral valve was leaking, the ischemic mitral one. Patient was so let's say, fragile. I said, I will replace this valve, and I had rupture, LV rupture. So it's not, I agree that if you can replace is not without any risk. I had rupture on really very normal one of the LV. Yeah, Manuel.
One more comment, please.
Yes, a very quick technical point. You both showed that you could repair the valves with immediate, very good results. But just concentrating on your last second case, this, and I'm surprised that you didn't think about that detail, this patient was asking for the magic stitch fusion of that commissure.
Oh, yes.
Together with the ring, I think you would have a greater guarantee that it would last for a long time.
You mean the ischemic one, the chronic, the last one?
The chronic.
Yes.
Talking just about the chronic.
Yes.
That is such a located area. If you fuse that, usually you have a very large annulus in any case, and very large orifice. So if you reduce it a little bit by just plicating that commissure will be perfect.
You mean, P2 to the commissure, occlude all this area.
P3 to A3.
Very short, please.
Very short comment. Okay. More than 50% of the cases, I cut the secondary chordae, but I'm not still arrested, not in the jail. It can work.
Yeah, I will call Robert Dion.
And another thing is, I don't think the ring is a sole solution because the ring deteriorates the posterior tethering, and also it makes us functional mitral stenosis. It's a big problem. So definitely, I think you need some kind of subvalvular procedure in combination with the ring.
That's open for discussion. That's why I present this case. Yeah.
Okay, thank you. We'll move on to my co-chair, Dr. Chang, who will talk about mechanical versus tissue valves.
Good morning. We have a nice discussions for mitral valve repair in ischemic MR. But this morning, I'd like to talk about selection of prosthetic valve in aortic valve replacement in 50s, where with a limitation of time, I'd like to skip several slides. Well, this morning, Dr. Wu supposed to prefer mechanical valve prior to me, but unfortunately, he did not come to Chiang Mai, and probably I win the TOPGUN competition due to absence of Dr. Wu. Well, long-term mortality benefit that was associated with a mechanical prosthesis persisted until 55 years of age among those undergoing aortic valve replacement, and he was a star in 2017. So he insisted that until 55 years of age, among those undergoing AVR, had a better long-term results. We know actor And Mayor of Los Angeles, Mr. Arnold Schwarzenegger, received the aortic valve replacement in 1997 when he was 50. And he opted against the mechanical aortic valve and chose tissue valve because he felt a mechanical valve might limit his physical activity and the capacity to exercise. And 2 years ago, we learned that Mr. Arnold Schwarzenegger required the second heart surgery of pulmonary valve replacement. Here, Dr. von Steins, president of our AHS, stood behind him. Currently, the AHA recommended mechanical valve. According to the 2017 ESC and EACTS guideline, bioprosthesis is recommended when good quality of anticoagulation is unlikely. It's class 1. And the bioprosthesis should be considered in patients for whom there is a low likelihood and or a low operative risk. Sorry. And the 2017 AHA-ACC focused update demonstrate that patients less than 50 years of age who do not have a contraindication to anticoagulation, the mechanical valve is recommended. However, it was modified in 2017. The age limit of mechanical prosthesis was lowered from 60 to 50 years of age. There have been significant changes of trend in bioprosthesis or mechanical valve in aged 18 to 50 years in California State and New York State, from 14% to 47%. Let me introduce a case of aortic valve replacement with a tissue valve prosthesis. The 56-year-old gentleman visited with exertional dyspnea in 2018, and echocardiography and aorta CT demonstrated severe aortic regurgitation with a dilatation of a sinotubular junction and ascending aorta. And we discussed to select a prosthetic valve, whether bioprosthesis or mechanical one. The post-operative course was uneventful. After receiving ventral operation with the Carpentier Magna Ease and the Cox-Maze procedure. And he received the post-warfarin for 3 months. The preoperative echo LV end-diastolic dimension was 71, a very huge left ventricle with a moderate to severe aortic regurgitation. Post-operatively, the patient was good, but unfortunately, 9 months after the operation, the patient was suffered from headache and sudden hemiplegia with intracerebral hemorrhage. After drainage of intracerebral blood, the patient was recovered, but he had a sequelae of right hemiplegia. If he had mechanical valve and the long-term anticoagulation, there will be a significant problem with anticoagulation. For selection of valve prosthesis, we have to discuss for the risk versus benefit of each prosthesis. The surgical mortality would be 1 or 2% for the first operation to the STS score, and if he needs a second operation, the mortality rate, ST score would be 2% or less than 4% with comorbidities, especially with Dr. Patterson's group. His second operation was less than 4% mortality. What about the anticoagulation-related mortality for 15 years? It should be more than 10% if annual incidence of complications of anticoagulation-related bleeding, 0.7% per patient a year, or 1%, it would be 15%. And after redo operation with a tissue valve, he can receive TAVR when he is 80 or 85, so he can live more than up to 90 years. In 2017, Dr. Goldstein and associate in Stanford University did a very important clinical research regarding selection of mechanical valve for aortic valve replacement in 50s. Those group analyzed the long-term survivor free from and free from reoperation and hemorrhage. This is a long-term survivor. And a patient's age is between 45 to 54 years. There was a significant mortality difference between biological and mechanical. However, patients over 55, there was no differences in long-term mortality. So when age was examined as a continuous variable, the relative mortality benefit that was associated with the mechanical valves persisted until 53 years of age. So Professor Wu concluded with the analysis of statewide California database, the long-term mortality benefit that was associated with mechanical prosthesis as compared with tissue valve prosthesis until 55 years of age among those undergone AVR. So although mechanical valve prosthesis was associated with a significantly low risk of reoperation than was the implantation of biological prosthesis, mechanical valve were associated with a higher rate of bleeding and in some age group, strokes. The mortality for reoperation would be less than 5% in Dr. Patton's group, and mortality with a stroke and anticoagulation-related bleeding would be 10% to 15% at 15 years. Meanwhile, Dr. Xiang and associate of Dr. David Adams' group, New York, reported retrospective cohort analysis with 4,253 patients aged between 50 to 69 years who underwent primary isolated AVR. Using bioprosthetic versus mechanical valves in New York State from 1997 through 2004. And they did a propensity matching and yielded 1,001 patients pairs. This is overall survivor of AVR among propensity matched patients aged between 50 to 69 years. There's no differences in actuarial survivor between bioprosthesis and mechanical valves. This is cumulative incidence of stroke. Bioprosthesis were associated with a significant higher rate of redo operation, as we can expect it after AVR, than mechanical prosthesis. Mechanical prosthesis, however, were associated with a significantly higher rate of major bleeding compared with the bioprosthesis. The 30-day mortality of redo operation was 9.2%, and the 30-day mortality with major bleeding was 13%. There was no difference in stroke rate between bioprosthesis and the mechanical valves. The cumulative incidence of stroke at 15 years was 7.7%. And this is a conclusion. They concluded that there was no significant difference in 15-year survivor or stroke. And they suggest that bioprosthetic valve may be a reasonable choice in patients aged 50 to 69 years. And this is bioprosthetic aortic valve replacement written by Dr. Schnittmann from the same group of Dr. David Adams. And 5,111 patients aged between 18 to 50 years undergoing primary AVR in California State and New York State between 1997 and 2006. Kaplan-Meier survival curves in ages 18 to 50 years. There was a hazard ratio was 1.14. There's no significant differences between them. And there is so far no randomized retrospective studies, bioprosthesis, more used in coexisting conditions. And this is a summary slide. In California state, Dr. Wu, this is a summary slide. Today, I am here as a striker for the long-term TOPGUN session to attack mechanical valve for 50s requiring aortic valve replacement. They have more numbers of patients and more time period in California group. However, there's no propensity match the scores. They prefer mechanical valve. However, New York group, the number was about 60%. However, they analyzed the data with the propensity match the scores. And they prefer biostatic valves. Although there is still limitation of durability, less than 20 years in aged patients, there have been significant improvement in its durability and design up to, with the improvement of design, the durability up to 15 to 20 years at this time. Biologic prosthesis associated with a significantly low cumulative incidence of stroke and bleeding. And recent improvement of surgery, risk of redo has been decreased significantly, less than 5% in large volume center. And later, we can manage them with the valve-in-valve with the TAVR when their age is more than 80 or 70, more than 75 years. So I'd like to say, bioprosthesis for AVR may be a reasonable choice in patients aged 50 to 65 years. Well, last year I won the gold medal in the final round of the Seoul judo competition because my opponent withdrew the competition because he had a back pain. Well, this time at ASCVTS, fortunately, my opponent Wu could not come to here, so I can get the gold medal with the support of Dr. Adams and Dr. Chikwi. Thank you very much for your attention.
Wonderful and clear talk. One question for them from the auditorium. I think, yeah, there's.
Thank you for a nice presentation. I have a question to you about the risk of endocarditis in mechanical versus tissue valve. And there are some Scandinavian data that say that the bioprostheses have a higher risk of endocarditis, which to me seems pretty credible.
Well, so far, I don't, it is very difficult to answer, but according to the literatures published up to now, the incidence of endocarditis with the prosthesis in biological valve is not worse than the mechanical one. There's no report so far, so I don't know.
There are two reports from Scandinavian registries, both in Sweden and Denmark.
Yes.
Glaser from Sweden and Östergaard from Denmark, a nationwide study.
I mean, I don't know if it is a question or comment. If you look at those patients between 18 and 50 years, whatever is the prosthesis, mechanical or biological, the survival at 15 years is around 60-65%. So we have such a kind of excess of mortality in those patients. what about Ross operation in those patients? I mean, the survival in this group of patients having Ross is excellent. It's 90–95% in some centers. So we talk about mechanical, biological, but no word about Ross. Can you comment on that?
Yes, thank you very much. It is a very important questions and issues at this time. But can you tell us that long-term structural valve deterioration with the Ross operation at 20 years is around 50–60% also? It will not last forever. We have to think about, well, it's depend on the surgeons and institute operated, but I don't know exactly. The Ross operation is good for long-term result, requiring who does not want to have anticoagulation is good option. But it is better than, I think, the tissue valves.
I mean, in our experience, in our approach, any patients between 18 and 50 years, if he has aortic stenosis, he will be offered Ross operation.
Yes.
In our experience, the freedom from any valve related at 15 years is around 90%. So, and the freedom from reoperation, even if we have to reoperate, we are not going to replace this valve. So freedom from replacement is even 95%, 97% at 15 years. So Ross operation, I think, if we don't have to forget it. I think we have to learn it again. This operation, and it offers a lot of advantages for this kind of population.
Yes, it is important. You know, Mr. Arnold Schwarzenegger received the pulmonary valve replacement because of previous Ross operation.
I know, yeah.
Was done. So reoperation, free from reoperation for Ross operation also requires a pulmonary valve replacement.
Yes.
15 to 20 years later.
Yes.
Yes.
Okay, we have to move on. Thank you very much. And I think we should right away start with the next session, Practice of Excellence. And I thank all the discussants for the very fruitful discussions in the first session. I think we learned a lot. And let's right away move to the next one, please. I ask my co-chair, Dr. Schaft, to come up to the podium, and Michael Gardner to give his first talk. Arzt Schaaf will start with his talk first. Topic is best AVR, surgical, sutureless, or transcatheter.
Do you have the slides? We've had a change in the agenda this morning. So. Right, thank you. And I apologize for perhaps repeating some of the information that you heard in the previous discussion, but I think it might be interesting to hear a different perspective on the same data. And I have no financial interest in valve substitutes, but every time I'm in front of surgeons or cardiologists and you talk about valves, I'm reminded of what Mark Twain said. He said, it ain't what you don't know that gets you in trouble, it's what you know for sure that just ain't so. So keep that in mind as we go through some of the information. Now, we'll start off with a couple of cases. I don't have a audience response, but I'll just ask you to think about how you'd manage two patients. The first is a 66-year-old hospital administrator, minimally symptomatic, but had just retired, wanted to be active in retirement, had severe calcific aortic stenosis with a valve area of 0.7, and he was advised to have his valve replaced so that he could maintain an active lifestyle in retirement. So think about what you would do for that patient. Would you do TAVR, he's low risk, surgical aortic valve replacement with a bioprosthesis, perhaps use a mechanical valve and anticoagulation, sutureless surgical aortic valve replacement, or something else, maybe, as Dr. Curry suggested, a Ross operation. That's the first patient. The second patient is a 22-year-old man with rheumatic heart disease who has endocarditis. The endocarditis was cured medically, but he had severe aortic regurgitation and mild mitral stenosis. As I said, the infection was controlled, but he was referred for operation. Would you do TAVR, surgical aortic valve replacement with a bioprosthesis, mechanical valve, Ross procedure, homograft? So those are two patients, a 66-year-old man and a 22-year-old man. Now, let's just take a few facts. First of all, there's increasing popularity of bioprostheses, as you've heard from all the discussions this morning, among physicians and surgeons. The second fact is that patients don't want to take warfarin. I've never had a patient come into my office and ask to take Coumadin. But most patients misunderstand Coumadin and the implications as regards their lifestyle. Another fact is that industry suggests that there's better durability with third-generation bioprostheses. And finally, the cardiovascular community has accepted valve-in-valve with TAVR as a solution to bioprosthetic degeneration. So why in the first place select a bioprosthesis? Well, I've heard some people say there's a lower risk of thromboembolism compared to a mechanical valve. Audience response? Is that true? Is it false? Or are you uncertain? Well, I think one thing we can agree upon is, from all the data, is that there's no difference in thromboembolism between an anticoagulated mechanical valve and a tissue valve. We always lament the absence of randomized trials, but actually there have been 2 randomized trials of mechanical valves and tissue valves. These are older trials with older valves that are no longer in use, but the VA study showed no difference in thromboembolism or endocarditis with Bjork-Shiley versus a Hancock. The Edinburgh trial from 75 through 79 also showed no difference in thromboembolism. And in more current era, this is the same information that you just saw. This is from New York State that looks at the risk of stroke amongst propensity-matched patients with mechanical valves on anticoagulation and bioprosthetic valves. The risk of a stroke is a little less than 1% per year and absolutely no difference between mechanical valves and biological valves. So, lower risk of thromboembolism? Nope. Well, you say, well, if we have no difference in thromboembolism, the advantage then is that you avoid Coumadin and the risk of bleeding. And it's obvious that if you have a population of patients on Coumadin, you're going to have a higher risk of bleeding. Some people, I think, misunderstand that and tell patients they have no risk of bleeding. But let me go over this a little bit further. Is that true? You avoid Coumadin and the risk of bleeding? Is it false? Are you uncertain? Well, as you saw earlier, this is the New York State data. It's exactly the same whether you're in New York State or whether you're in Sweden. If you look at the risk of bleeding, it's higher in patients with mechanical valves who are on Coumadin. It's about 1% per year. But look at the risk of bleeding with a bioprosthesis. It's about 0.6% per year. So is the risk of bleeding lower? Answer is yes. Do you eliminate the risk of bleeding? The answer is no. Now, why is that? Well, one reason is that if you take a group of patients with bioprosthetic valves and follow them long enough, a number of them will be on Coumadin. And this is from the Edinburgh trial that looked at patients 15 years after having a bioprosthesis. In blue, you can see the aortic valve patients. At the end of 5 years, 16% were on Coumadin. At the end of 15 years, a third of the patients were taking Coumadin. If you look at the mitral position, a third of the patients were taking Coumadin with a bioprosthesis at the end of 5 years, and almost 60% were taking Coumadin by 15 years. So you really don't avoid Coumadin when you use a bioprosthesis. Now, this is a patient of mine, a patient that had a partial AV canal. We repaired the valve. That didn't work long term. She needed a valve replacement and wanted to carry pregnancies through, so we used a bioprosthesis in the mitral position, and she developed valve thrombosis. We often think of valve thrombosis with a mechanical valve, but it can happen with tissue valves. And when I show this at other places, I have some surgeons that say, we don't see that. And when I hear that, I know that they just don't look for it. This is another man. This is a patient of mine, a ER physician who had severe aortic regurgitation, low ejection fraction, had an aortic valve replacement. There's two groups of patients who don't want to take Coumadin. ER physicians and neurosurgeons, because they know the problems with anticoagulation. So this guy didn't want to take Coumadin. This is his valve 2 years after aortic valve replacement. He had bioprosthetic valve thrombosis. Now, it happens with TAVR valves as well. This is an inoperable patient who developed valve thrombosis and then had a successful operation 1 month after implantation. This is a mitral bioprosthesis, and when you look at the image on the left, you might think that's endocarditis, but that's not endocarditis. It's thrombus formation on the valve. And we have quite a large series of patients who have had thrombus on bioprosthetic valves that are treated with anticoagulation. If you treat these patients with Coumadin, you can reduce the gradient. In this patient, after 3 months, the gradient was reduced from 11 millimeters of mercury to 7. So valve thrombosis in bioprostheses does occur. We once wrote a paper suggesting that you don't need to take Coumadin after bioprosthetic aortic valve replacement, and we were probably wrong. This is a study from Denmark that looked at the duration of anticoagulation. So if we know that there's valve thrombosis and we decide to treat a patient with Coumadin for the first 3 months after surgery, how long should we continue? Well, is it 6 weeks? Is it 3 months? Or do you just use aspirin? This study showed that if you have Coumadin for 3 months or even up to 6 months, you reduce the risk of thromboembolism. But more importantly, if you look at the risk of cardiovascular deaths, the risk of cardiovascular death is reduced in patients with bioprosthetic aortic valve replacements who take Coumadin for the first 3 months, and it's also significantly lower in patients at the end of 6 months. So not only should we be using it for 3 months, it's possible that we should be using it for 6 months. But it's clear that patients would benefit from Coumadin early after bioprosthetic valve replacement. And they summarized by saying that within 90 to 180 days after surgery, we found that for every 23 patients not being treated with warfarin, 1 patient died from cardiovascular causes. Now, you may say, well, I deal with elderly patients and we don't want to give them Coumadin because, of course, it messes up their life. Well, is that true? This is a study that looked at quality of life amongst octogenarians that had mechanical valves and tissue valves. And the mechanical valve group is in red, the tissue valve group is in blue, and there's absolutely no difference in the quality of life in all of these domains. Now, I'd like to show this one to cardiologists because if you look at, this is an Italian study, and they compared it to Italian population that didn't have surgery, and it looks like surgical patients, whether you choose a bioprosthesis or a mechanical valve, are happier. So, do you avoid Coumadin and risk of bleeding? Well, I'd say sort of. Now, what about this issue of durability? We've been told by our industry partners that there's better durability with the newer pericardial valves, and then if the valve fails, we can use TAVR. Is there better durability? I think you can see where this is going. True, false, or uncertain? Well, pericardial valves can fail, just like the old Ionescu-Shiley valves can fail from tears at the commissure. They can also fail because of pannus ingrowth or calcification, as this patient had 3 years after implantation of a tissue valve. And it's very important when we tell patients that a valve may last 12 to 15 years, that if you tell them 15 years, that's an average. That means some fail at 10, some last 20. But some patients who come back early are very disappointed because they understand that the valves last for 15 years. Now, when we looked at our patients, this is about 3,000 patients that had bioprosthetic aortic valve replacement. We divided them up into the newer generation pericardial valves and the older porcine valves. We didn't have enough patients to look at individual brands, but if we just look at pericardial valves versus tissue valves, and look at patient survival, not survival of the valve, but patient survival, the curves really are superimposable up to 6 years. After 6 years, they diverge a little bit, but look at how they diverge. Actually, the patients that had porcine valves survived a bit better than the patients that had pericardial valves. So there's no evidence, if you look at patient survival, that there's better durability, or at least if there is better durability, it's not reflected in patient survival. Now, we talk about durability of stented bioprostheses, but there is some information that's coming out now on durability of TAVR valves. And this was alluded to earlier this morning by Tony PLENARY. This is a recent 5-year follow-up of the PARTNER 2 trial that was published in the New England Journal in January. Now, and this maybe speaks to the points he was trying to make, because if you look at the conclusion from the trial, it says among patients with aortic stenosis who were at intermediate surgical risk, there was no significant difference in incidence of death or disabling stroke at 5 years after TAVR as compared to surgical aortic valve replacement. So, case closed. But there's very interesting information in this follow-up. This is the survival or the cumulative incidence of death or disabling stroke. And as was pointed out earlier, the lines seem to cross between 24 and 36 months. And when these data were presented at TCT, Vino Thorani did what was called a landmark analysis. And in the landmark analysis, you take the patients, all the patients who are alive at 24 months, and you say, let's make that times 0. And if you look at survival of patients from 24 months and beyond, there was increased risk of mortality in patients that had TAVR valves versus patients that had surgical aortic valve replacement. And the curves seem to be separating further. Now, apparently when the paper was published, they didn't want to include this analysis in it, and maybe that was because it was not a pre-specified method for analysis, but it's an interesting point that we all should watch. It was, it held true for the transfemoral cohort as well as for the overall group. But the other part that was very interesting in that New England Journal article is this, that intervention in TAVR valves was 3.2% versus 0.6%. That's almost a 4-fold increased risk of re-intervention. And this is something that surgeons have always wondered about. If you take a tissue valve and you mount it in a stent and then you dilate it, does that have anything to do, or you increase the stress on the valve, does that have anything to do with durability? I think surgeons, when we first heard about TAVR valves, were skeptical, but at least early on there was no difference. On the other hand, when you look at the 5-year data, there may be a difference in durability between TAVR valves and stented bioprostheses. Now, what about using a valve-in-valve as a bailout when you do have bioprosthetic valve degeneration? These are data from our institution, and so I know they're correct. They may not be the best in the world, but they're perfectly accurate. One of our surgeons, Kevin Greason, is very active with TAVR and put this together. And when we look at treatment of failing bioprosthesis, we look at surgical replacement versus TAVR. We had 260 surgical aortic valve replacements done for bioprosthetic valve degeneration during the same interval as 90 valve-in-valves. We saw that there was a 44% incidence of patient prosthesis mismatch that was severe in the TAVR group compared to 12% in the surgical group. But more importantly, if you look at patients that received a valve size 23 millimeters or less, and remember almost 70% of patients in the United States that have a valve replacement have a valve that's 23 millimeters or less. When you look at the incidence of severe patient prosthesis mismatch, it's 63% in the valve-in-valve group compared to 17% in the surgical group. Well, better durability, not much, or at least not any that we can find. A lower risk of reoperation in TAVR depends on how you look at it. You certainly do increase the risk of leaving the patient with prosthesis patient mismatch. Now, what about this business of survival? You say, well, all that may be important, but we know that the survival is similar to mechanical valves. True? False? Or are you uncertain? Well, it turns out that in the randomized trial, this is the VA trial. Now, in the VA trial, there was a significant improvement in survival with patients with mechanical valves at 15 years. And we tried to repeat the equivalent of the VA trial at our place when we looked at patients 50 to 70 years of age and looked at the newer generation of valves. We looked at patients that had pericardial valves and patients that had bileaflet mechanical valves, and we matched them for every characteristic that we could, and we found that survival of patients with mechanical valves was better. And this was not a very popular paper. In fact, it received considerable criticism, a lot of criticism from New York. But the improved survival was independent of all the other risk factors. So even after matching the patients, we did a multivariable analysis, and the hazard ratio for mortality was reduced in patients with mechanical valves. Now that's what led, I think, David Adams' group to look at the New York State Registry, and in the interest, like Fox News, to be fair and balanced, I'll show you this one that shows no difference in mortality between mechanical valves and bioprosthesis. But that's the exception in general. There's been improved survival shown with mechanical valves in Vancouver, in the United Kingdom, in Sweden. This is a nationwide survey of patients that had aortic valve replacements from 50 to 69 years, and there was a significant improvement in survival of patients that had mechanical valves. In this study from Sweden, you see the identical points that I made earlier. There's no difference in stroke, and you do reduce bleeding, but you don't eliminate bleeding with a biological valve. Now, this is what Dr. Chang showed you earlier, and this is the study from Stanford that looked at the relative mortality with a bioprosthesis versus age. So the hazard ratio for mortality, and it's interesting how people interpret this, because the conclusion from the study was that there's no difference in mortality when you get to age 55. Now, is that what you see there? Well, what you see there is you see the confidence interval crossing 1 at age 55, but you don't see the line of unity getting down to 1 until age 65. Now, you can argue that statistically there's no advantage, but I would ask you to look at this a different way. Look at it this way. What age group on that slide is there a survival disadvantage for using a mechanical valve? If you pick a mechanical valve, which age group are you disadvantaging? The answer is none on that group. Now, if you look at mitral valve replacement, the point at which survival of mechanical valves and tissue valves is about the same is at 70 years of age, not 55, not 65. And once again, look at it the other way. At what age do you disadvantage a patient by using a mechanical valve? Well, by using a tissue valve, you've disadvantaged the patients up to about 70, but even after 70, there's no real disadvantage in terms of subsequent survival using a mechanical valve. And this has been shown, and it's a small difference in survival, but it's been shown in meta-analyses too, and this is a recent meta-analysis. Now, I would say probably not. I don't know whether there's a survival difference, but I can tell you there's plenty of data that suggests that there is a small survival advantage with mechanical valves. So let's get back and I'll finish up. This is that cases that I showed you earlier. 66-year-old retired administrator with severe aortic stenosis, had his operation elsewhere, had a 23 millimeter bioprosthetic valve put in 2011, and 3 years later he came to Mayo Clinic because he had a prosthetic gradient of 68 and a valve area of 1, and he was not a happy camper. The 22-year-old boy, I maybe misrepresented this patient a little bit. He had endocarditis that was healed, but severe AR. He actually had his operation in 1972 with a Starr-Edwards valve. And when I saw the patient 40 years later, he had developed atrial fibrillation with a tachycardia-induced cardiomyopathy, and the cardiologist asked us to come see him because he said, he's got a really old valve in there. Do you think it ought to be taken out? He had a normally functioning prosthesis with a 14 millimeter gradient and no AR. And I show this just to make the point that we often underestimate or undervalue durability of heart valves. And I'll just show you one last one. This is an email that we received from a patient that Dr. Magoon operated on in 1965. So he's an 83-year-old man who wrote to us and he said, my aortic valve was replaced with a Starr-Edwards mechanical valve by Dr. Dwight Magoon in 1965, has operated flawlessly for over 50 years, and it's occurred to me that upon my demise, the valve could be of value for research purposes or simply to put in the museum. Thank you.
You want to stay for discussion? Yeah, that was a really excellent overview, very thoughtful. There might be a lot of questions, actually. May I start with one comment? You said your topic was reoperations with bioprosthesis, and you quoted your results from the Mayo Clinic with valve-in-valve procedures, showing that in a 23 millimeter valve, if you put in a transcatheter valve, you get high gradient and severe patient prosthesis mismatch. Now, we have the same results, however, only with the SAPIEN prosthesis. If you put a self-expanding Evolut prosthesis into a 23 millimeter valve, you will not have high gradients. And also in our institution, every biological valve up to the size of 23 is cracked, and we put one size bigger transcatheter valve prosthesis in it. So this is a way to go around this. The other thing that you mentioned is very true. There are hints now, more and more, that there is some early thrombosis, which is more frequent in transcatheter valves than in biological valves. As to my knowledge, nobody knows why this is, but it's a phenomenon that is observed right now, and some cardiologists even propose to put those patients for the first year on anticoagulation. Any other comments?
Thank you.
Hartzell, I have a question. Do you think there could be some population differences between Minnesota, New York, California, Oregon that contribute to these survival differences?
I'm sorry,
Do you think there could be population differences in New York versus California, or New York versus Minnesota, New
Yeah.
York versus Oregon, that could contribute to some of these differences? As an example, we have the exact same data that you have for long-term survival out to, our data go out to 50 years now for mechanical, out to 35 for tissue in Oregon, and we see the exact opposite thing in terms of porcine versus pericardial. And when I look at that, and we almost have the exact slide that diverges at the exact same time, but in a different way. And then I see the ones from New York that are different for survival than yours, and the ones in New York different from California. I have to start wondering about, are there population differences that could impact that?
I think that's true, and we did not try to adjust those two groups. So the porcine and pericardial valves could have been slightly different eras, and it could be different patient populations. So that has to do with pericardial versus porcine. The issue is if a pericardial valve lasts longer, we're talking a couple years, mean or average. I mean, I don't think anybody would propose that the pericardial valves last forever. So maybe there's some improved durability. We don't see it as reflected in patient outcome. I accept that there may be a difference in your patients. Yes?
Well, my name is Bis Chang from Seoul, Korea. Well, I have just the simple questions for you. And what is the instance of redo operation in mechanical valve in aortic position? And second one is it influenced by the prosthetic valve size? You are expert for augmentation of annuloplasty for aortic valve replacement. Is it influenced to the reoperation for mechanical valve? Thank you.
Yeah, I can't give you the precise number for reoperation. It's clear that any valve you put in has some risk of subsequent reoperation because of pannus ingrowth beneath the valve and that sort of thing. But I don't have a number for you. I'm sorry.
What about the augmentation annuloplasty when you replace the aortic valve? The size of the aortic valve prosthesis influence the long-term outcome for redo operation?
We've not looked at it in just redos. We've looked at it carefully when we look at even mechanical valves. When we look at prosthesis patient mismatch, we see reduced survival when there's severe mismatch, but not when there's moderate mismatch.
Well, according to the Dr. Chiang's report from the New York, the instance of reoperation for mechanical valve prosthesis was about 7 to 8%. So this is not low, even in mechanical valve. Thank you very much.
Mm-hmm. Yes, Chris.
Thank you for the talk, Dr. Schaap. We had a question yesterday in the aortic valve session about sutureless valves, and I promised them that you were going to give an opinion on sutureless rapid deployment valves. Can you briefly tell us what your opinion is on how the sutureless rapid deployment valve plays into ABR right now?
You know, I'm not sure it changes any of the discussion that we had about selecting valves for most patients. I suspect there may be some specific cases where a sutureless valve is helpful. If it's a particularly long case, Surtec has a lot of experience with sutureless valves and maybe can help us there. So if there's a time constraint, that might be helpful. There are certain patients that have difficult exposure if there's calcification and stiffening of the aortic outflow and you have difficulty putting your sutures in, that might be an area where you'd use a sutureless valve. Are you talking about a sutureless valve or? Yeah. But I don't think it changes what the calculus that we just talked about here.
May I just add one comment to this? I think the sutureless valves have a significantly higher pacemaker rate than surgical bioprosthesis. The pacemaker rate lies in surgery. We talk about 4 to 6%. For sutureless valves, you have to expect 8 to 10%.
That is exactly our experience, and we recently matched and reviewed our results at Mayo and matched the patient group with sutureless valves and conventional surgical aortic valve replacement. The only advantage is cross-clamp and pump times, and which is, I don't know how reflected to the clinical outcomes. There's no difference with regard to clinical outcomes. The only advantage is shorter cross-clamp and pump times, and pacemaker rates definitely higher compared to between 4 to 6 for conventional, and it's around 10% for the sutureless aortic valve replacement. However, there's kind of a trend with regard to the operator experience, and more with some modifications, pacemaker rate could come down, but there's no major advantage except shorter cross-clamp and pump times, which is not reflected to the clinical outcomes. Also, I just had one question. If you match the mechanical aortic valves, and this is always kind of missed, and tissue prosthesis with regard to the post-operative gradients and left ventricular mass regression, what is your experience? Which valves are better with regard to the hemodynamics?
I don't know how to answer that. I think we make a lot out of mass regression and how fast the mass regresses. The real issue is patient survival. I don't know the answer to that, of whether there's better mass regression with one type of a prosthesis or another. Depends on the gradient in the valve area, I think.
Yeah, my name is Zolin from New Zealand. The sutureless valve yesterday was my question, and thank you, Chris, for remembering it. One thing I want to add about sutureless is that it does give a better gradient on it. My question now to you is just about confirmation of what your current practice is for the tissue aortic valve. Are you warfarinizing them now, and what is the duration?
Yes, well, as I mentioned, I've gone from saying you probably don't need it, just give the patients aspirin, to anticoagulating them for 3 months, and then if they're not having any problems maintaining adequate anticoagulation, I would encourage them to take it for 6 months. So that's been quite a change.
Thank you, Dr. Schaff. You mentioned in North America, even 70% of the patients received a size less than 23 tissue valve.
No, 23 or less.
Yeah, so I guess this ratio could be even higher in the Asian population here. And I just wondering, because Mayo Clinic was one of the center early use of trifecta tissue valve, whether this improve slightly in terms of patient prosthesis mismatch. Trifecta got other disadvantage. When you do valve in valve, you cannot fracture the trifecta annulus. So whether you still consider trifecta carries some advantage in terms of use smaller size tissue valve.
Okay, well, that's a good point. And I'll say this, and it gets back to this issue of whether the current generation of valves are more durable. I think there's no question that the design results in lower gradient. So I think that the trifecta valve or any of the newer pericardial valves probably have lower gradients than the other valves. But as surgeons, we get much too wound up on whether the gradient at 3 months is 8 millimeters or 12 millimeters. What really matters is the gradient at 10 years. If your valve is failing at 10 years and you have regurgitation or prosthetic aortic stenosis, it really doesn't matter whether you started out with a gradient of 6 or whether you started out with a gradient of 12. We spend far too much time talking about relatively small differences in gradients early after surgery, I think.
I enjoyed your presentation very much. In your presentation, you never included the Ross procedure or the homovital valve. You do a lot of transplants, and the valve from the recipient of the heart transplant could also be very useful in such patients, particularly those who have endocarditis.
Well, we've had a large experience with homographs, and in our experience, the homograph does not last longer than a stented bioprosthesis. It's especially useful in infection when you have to use the anterior leaflet of the homograph to reconstruct the outflow tract. So we use a homograph in patients with endocarditis, but not with an expectation that it'll last longer than, say, a stented heterograft.
The homovital valves, which you take out of recipients?
Well, we've not, I mean, maybe we've just been, we've only used the cryopreserved valves. We've not used fresh homographs.
Thank you.
I'm Dr. Chaivut from Thailand. I'm very glad to see you. Year 2000, I spent short time in Mayo Clinic with you, and you taught me a lot. I have two questions. First, in practice, if the patient underwent the mitral valve replacement for rheumatic mitral valve disease 30 years ago with the Starr-Edwards valve and come again with the severe aortic stenosis, which type of valve do you prefer? At around maybe right now, patient is 66 years old. The bioprosthesis or still keep the aortic valve replacement with the mechanical valve, because the first time he underwent the Starr-Edwards valve in mitral valve position. And the second question is in tricuspid valve stenosis after mitral valve surgery, which type of tricuspid valve replacement do you prefer? A mechanical valve or bioprosthesis if the patient is still young?
Yeah, for the first patient is an interesting one because there are some patients still around that have Starr-Edwards mechanical valves in a mitral position. If the valve is working normally, I wouldn't replace it. I would just use a mechanical valve in the aortic position because the patient's on anticoagulation anyway. For the second point, what do you do for the tricuspid valve? Well,
TSTR, maybe a patient come again after mitral valve replacement, and patient come again with a rheumatic tricuspid valve disease such as the severe tricuspid stenosis or regurgitation, and cannot repair the tricuspid valve. So patient still young, and maybe quite a lot.
We have used mechanical valves in the tricuspid position, but not nearly as many as tissue valves. We would generally use a tissue valve, even if the patient's on anticoagulation, for a left-sided valve anyway. The durability in the tricuspid position is probably better just because of lower pressure and that sort of thing.
Thank you very much.
Good morning, sir. I'm Dr. Swapnil Deshpande from India.
Yes.
We get a lot of young patients for valvular heart disease, but our problem with most of the patients, even if we put a mechanical valve, is drug compliance. So we have lot of patients who are opting for a tissue valve, or a surgeon is opting for a tissue valve just to avoid any emergency valve complications. So what can be your take on that? And what will be your age for selecting a patient that this patient is going to go for a mechanical valve or this patient is going to go for a tissue valve?
Well, those local socioeconomic issues are important in selecting a valve. I'm not saying that a mechanical valve is right for every young patient. So I understand the problem of maintaining adequate anticoagulation in an underserved population. So, we have to do the best and make the best judgment that we can for what's best for the patient. Now, I don't know in your circumstance what the problem is with maintaining anticoagulation. I gave a talk on valves at a recent symposium, and a cardiologist from a very major center, when I said, well, the best practices is to have home INR monitoring. This cardiologist said, well, nobody does that. Well, we've been doing it for 15 years, or at least advising it for 15 years. And if your patients aren't doing home INR monitoring, you're missing a great way to reduce thromboembolic complications. and to improve the adequacy of anticoagulation, reduce bleeding. That may not be possible in the patients that you're talking about, and maybe you just have to use a tissue valve. So I don't have any easy answer.
What's your age cutoff for mechanical valve and tissue valve?
The age cutoff, at least, I would talk to patients about mechanical valve as an option, up to 65. And there are a few patients, and I've had the patients tell me, they say, well, wait a minute, my mother lived to 95 and my dad lived to 98 and I'm 65. Why wouldn't I take a mechanical valve? There are patients like that. So it depends a lot on the expected life expectancy and the patient's expectations, but I would still talk to them about a mechanical valve, patients well in their 60s.
Okay, thank you.
Gustav.
This should be the last question because...
Thank you for a very thoughtful presentation. I just wanted to make one comment about the trifecta valve, since that was mentioned. We have a presentation at the ATS that shows that the gradient advantage is gone before 5 years, and that the risk of reoperation is significantly increased already within 5 years.
All right, good point.
Okay, thank you very much. I now call Patrick Perrier to the podium. He will talk about the keyhole approach with no compromise valve repair.
Good morning, Mr. Moderators. Good morning, everybody. So we changed from aortic valve to mitral. I'm amazed to see that those subject on the choice of valve substitutes in the aortic valve is still very actual and raises so much question, and we still don't know. So keyhole approach. We know that mitral valve surgery and mitral valve repair has been performed most of the time through sternotomy, and this has been and still may be the gold standard. Minimally invasive surgery started, and so we'll discuss from the switch from medium sternotomy to minimally invasive surgery. Minimally invasive surgery started, in fact, in 1996, and the first one who published an article was Carpentier. And soon after, in Europe, two colleagues took the problem and put their energy to make it real. One is Friedrich Mohr in Leipzig, and the other one is Hugo van Herman in Halst. One has to say that if we look at the first reports, the results were depressing. This first report coming from Leipzig, hospital mortality was 9.8%. Overall morbidity was very high, and so it was depressing. Same thing in Aalst, in Belgium, with Hugo van Herman. You said that valve repair was only about 50% of the cases, and there were a lot of complications. So we wanted to start, and we started in the early 2000, the first days of 2000. And we, considering those results, we said, okay, we are going to organize ourselves to try to have better results. So the first thing that we did organize is that we need a team, dedicated team to do this. And we prepared with the team all together for a relatively long time, maybe 6 months, trying to see every problem, trying to solve every problem. Then we worked on the patient selection, and then we'll talk a little bit about our evolution. Our team. So our team consists of anesthesiologists, nurses, perfusionists, and surgeons. And this is our team from the beginning, and the team is stayed almost the same. A team, I must underline something, is not a group of people who work together. A team, a real team, is a group of people who trust each other, and this trust is very important. And we were very keen in the beginning to have very strong points. And one of them is that we didn't want to do any compromise. No compromise on the security and the safety of the operation, and no compromise on the quality of the results. It means that we had to apply the same techniques, the same philosophy, the same strategy that we applied through sternotomy, and that is to say for us to apply Carpentier's principle. Also, something is important is that if you are interested in mitral valve repair is if you take the degenerative mitral valve disease, we wanted to have the same rate of repair as the one which we can have through sternotomy, that is to say, almost 100% rate of repair. And another thing is that we wanted to do really minimally invasive mitral surgery. So it means that we wanted to do video assisted because you may really decrease the size of the incision because you look through the endoscope on the screen and not through the incision. And we didn't want to have a direct vision because you are obliged to do a bigger incision, and most of the time you're obliged to use a retractor. Sometimes you may break a rib, but at least you may compress the intercostal nerves. And so for us, from the beginning, it was clear that it was not really minimally invasive surgery. So this is not what we wanted to do. And what we wanted to do was something small incision, and it needed for us to have a good visualization of the mitral valve with the endoscope. And as cardiac surgeons, we were not trained at all to use endoscope. I mean, I was looking an endoscope like a cat would look at a fork. I mean, nothing. So when we started, we were very careful with our patient selection. So in the first phase, we started with very easy patients, the easiest that that we could select. Annulus dilatation, mitral valve replacement also was or very simple P2 prolapse that we could detect on echo that would be simple. And this is where the fact of having a center with a high volume of mitral valve is important because you can really select your patients among the patients who are coming to you. The second phase, we did isolated, moderately complicated mitral valve repair, and progressively we increased the difficulty. We increased the difficulty in terms of mitral valve repair, then adding ablation, then adding tricuspid repair. And so today we can do any kind of mitral valve reconstruction associated with tricuspid repair and with ablation. At the beginning, our concern even was always safety, as I said. So we did big incision. We didn't care about the cosmetic, and we saw through direct vision. We had no experience with endoscope. Then the second step is that we could decrease the size of the incision, still working mostly through direct vision, but training to work with the endoscope. So once you are at this step, you can train with the endoscope and you can improve your skills. And then once we were able to do the operation just by looking at the screen, we could really do small incision and just work with the camera. So this is our setup. From the beginning, our setup, we kept it very simple, and it's about the same setup today than the one that we started with. So we had one port for the endoscope in the same intercostal space as the incision. We have one 3D camera. We had 10 millimeter, 30 degrees endoscope. We have one left atrial vent. We have one arm for the camera. We have one Chitwood clamp. We have one line for the cardioplegia which goes through the chest wall, and we have the shaft for the LA retractor. The incision in the beginning, we did like everybody else. We did incision in the inframammary groove, but we could then, as I said, reduce the size of the incision. But then I realized that, in fact, what we wanted to go through is the fourth intercostal space. And the fourth intercostal space is higher. And so I kept saying to myself, well, why do we need to go through the inframammary groove if we want to reach a higher space? So I decided to go the incision right on the fourth intercostal space. And I did some horizontal, some vertical, until I said, well, why don't we do some periareolar incision, because this would be, on a cosmetic point of view, probably the most elegant. And so this is one case that we do. So this is a patient with the typical prolapse of P2, and as you can see on the echo, and this is the 3D. So we start to cannulate. We cannulate with the Seldinger method by placing purse strings on the vessel, on the femoral artery, on the femoral vein. We start to cannulate the femoral vein. We bring a guide wire into the superior vena cava. We do this under echo control. This is the venous cannula. And then we just continue. We do the arterial cannulation. Then we can do our incision, periareolar incision. And we go through the subcutaneous tissue. We recline the muscle. We don't want to go through the muscle. We try to respect the muscle as much as we can. And then we open the fourth intercostal space. And once it's opened, we place a soft tissue retractor. And at this point, we can place the endoscope, and then we can just look at the screen. So the image that you have is the image that we use to operate. So we put the cardioplegia line, we cross-clamp the aorta, we open the left atrium, and we have the exposure of the mitral valve. And most of the time, you have an exposure like this. It's easier than through sternotomy, and you almost always have a much easier exposure. So we do the valve analysis in exactly the same way. And if you don't see something, you can zoom with the endoscope and have the mitral valve as big as this. So in fact, you see better than with the sternotomy. And you see that there is this prolapse. You see those ruptured cords here that are here. And it's close to the indentation between P2 and P3. So we decided that we would close the indentation and that maybe it would be enough to treat the prolapse and stabilize the free edge of the posterior leaflet. So we do it like this. And so you are alone by yourself. So you have no assistance, no space for a third instrument. So you have to use a lot of tricks to help you, like to use the wall of the left atrium like this to put your free edge under stension and to expose what you want to suture. And then we just do a running suture to close this indentation. We start at the base. Can we move the video a little bit forward? In the sake of time. So we go to the free edge. We tie the nuts. And then we'll check the result if we did correct the prolapse. So we take our hooks and we see that there is still a remaining prolapse. So it's not an issue. We are going to treat this with Gore-Tex, and we will anchor the Gore-Tex on the posterior papimuscle, posterior head of the posterior papimuscle that you can't see very well. So at that time, I was doing probably a figure of 8. I did change recently. I used some mattress suture with a pledget for the Gore-Tex and the papimuscle to have both arms of the Gore-Tex, which can have the same tension. Go through the free edge, measure the length in comparison to the reference point, bring the free edge of the prolapse area at the same level than the free edge of the reference point, tie the knots, do the okay, then we'll place the ring, do the water test, and we have a good result. The echo was good, so I'm going to, okay, you see the echo is very good, no problem, no regurgitation. So on the cosmetic point of view, you see in the result after 1 week in a male, in a woman. At that time, I didn't dare to go around the areola in women, which I do right now. But you see that you still can have a very good result cosmetically. So our results on the first 842 patients, we did 99.3% repair, so we were happy with this. We did some concomitant procedures. The operation takes longer cross-clamping time, longer cardiopulmonary bypass time. But if we look at the death, our rate of death was 0.24%. We had some complications, as you can see, but in total, the major adverse events were 7.1%. We've had some conversion, immediate in the OR, mainly due to bleeding or to impossibility to expose the mitral valve in one case. And we had some delayed conversion in 16 cases, either due to bleeding or because we had to perform a CABG because of a circumflex obstruction. One big advantage is that the use of blood is really reduced, and in this cohort, we had a rate transfusion of 13%, and today we are around 5%. And if we look at the pre-discharge echocardiography, we see that 93% of the cases had either no or traces of regurg, and 6.5% had a grade 1 regurgitation. So we started to work with 3D in January 2015, and we did a study to compare the patient with isolated mitral valve repair that we did operate on in 2014 with 2D compared with the patient that we did operate on in 2015 with 3D. Both groups were identical, and there were no difference in well, there was a huge difference, in cross-clamping time. With 3D, our cross-clamping time was shorter by 11 minutes, which is a lot. Bypass time was reduced by 16 minutes, and operation time was reduced by 21 minutes. One may say, or 22 minutes. One may say, well, what is 22 minutes? You know, it's not very important. Well, I show you something. 22 minutes. We did operate 135 patients. So it means that at the end of the year, we were quicker, and our rate and the occupation time was decreased by almost 3,000 minutes. And in Germany, the price of 1 minute of operating occupation of the operating room is 25 euro. It's for all surgery included. Probably for cardiac surgery is a little bit more because we have more people. So at the end of the year, we saved 33,500 euros, which is about the price of the device. So within a year, we came to a good balance. So I would say that if we look at the evolution of mitral valve repair altogether, you see that it has been a very dynamic field, as you know, and there have been some constant improvements, some approaches, and there have been some milestones. And one of the most important milestones is transesophageal echo in the OR in the mid-80s. So this is but I think that minimally invasive surgery is also an important milestone, and it will change the surgery of mitral valve repair. And as a conclusion, I would quote a Japanese writer, Haruki Murakami, who reported in one of his books the mantra of a gold medalist marathon runner. And the mantra is the guy started to run his marathon and started at kilometer 30, started to repeat, pain is inevitable, suffering is optional. And I think that if you start minimally invasive surgery, it's a mantra that you should remember. Thank you very much for your attention.
Thank you, Patrick, for this excellent overview and for your wonderful results. We have time for a couple of questions. The opening ceremony will start at 10:10. So we still have a couple minutes. Other questions?
Thank you for a wonderful presentation as usual. We are promoting the robotic mitral valve surgery at the clinic. What's your, so to say, take on that, and what's the pros and cons of the two approaches?
I tell you, I have no opinion because I don't know robotic. So it may be preconception. Our approach is to make this type of surgery simple and to make it as efficient as far as its costs are, as far as costs are concerned, as efficient as possible. And we decided that to make the investment, to have those disposable that you need for robotic, and to have the maintenance every year and so on, it's a lot of money. And if you can do the same thing without spending all this money, why would you spend the money? But maybe robotic is something which is very nice, very good, but I don't know it.
The point I wanted you to make was that there's no incentive for you to go towards robotic.
No. So far, no incentive.
Are there other questions? This is not the case. Patrick, thank you very much. And thank you all for following the session. Thank you, my co-chair. So we'll have the opening ceremony at 10 minutes after 10.